care for older persons in the community. As you are aware, this segment of our population of persons who are 60 years and over and who number about 2.6 million are a high-risk group in terms of their susceptibility to COVID-19. Nutrition deserves special attention because as people reach older age, the correct diet is essential for their good health, more so than at younger ages. Healthy aging is associated with physiological, cognitive, social, and lifestyle changes that influence dietary intakes and nutritional status. As we ramp up our COVID-19 mitigation measures, I urge our healthcare workers to give top priority to older persons in our health facilities. They need to ask them about existing conditions they may have, verify last visit details and their medication that they are on. At this time, when we are fighting COVID-19, this cohort may not get the necessary geriatric attention from caregivers or even have proper access to optimal nutrition. Often, this cohort will be stressed, anxious, and fearful of leaving their households. In the normal aging process, inevitable and irreversible physical changes occur, such as poor food intake, reduced nutrient reserve, reduced appetite, changes in taste and smell, and difficulty in swallowing. In a developing country like Kenya, where high mass consumption indices have not been attained, the price of foods rich in micronutrients is discouraged because of the price factor. Older people have increased morbidity and mortality. Other significant age-related changes include the loss of cognitive function and deteriorating vision, all of which hinder good health and dietary habits in old age. Fellow Kenyans, due to the physiological changes of aging, decreased immune function, and comorbidities such as hypertension and diabetes, older persons are at significantly increased risk for COVID-19. Older adults are more susceptible to the infection itself and are more likely to progress to the severe and critical stages of the disease. In this cohort, many of the diseases they suffer from are due to dietary factors, some of which may have existed since infancy. These factors are then compounded by changes that occur naturally with the aging process. Daily optimal nutrition and physical activity is essential for all to stay healthy and live long. I urge health practitioners, educators, and caregivers to provide sound advice and support older people and their families in maintaining healthy lifestyles. Healthy eating in older persons builds immunity, prevents disease, and maintains good health. Older persons should therefore be supported to consume a variety of foods from different food groups. For example, such as staples, this is the maize, millet, sorghum, roots, and tubers. Legumes, such as lentils, cowpeas, pigeon peas, soya. And nuts and edible seeds, together with a moderate consumption of animal source foods Vegetable and fruits are important sources of vitamins, minerals, dietary fiber, plant protein, and antioxidants, and should be consumed in plenty on a daily basis. Fellow Kenyans, turning to our COVID-19 situation in the country today, we record 397 people who have tested positive after testing 3,637 samples over the past 24 hours. This now brings to 14,168 the number of confirmed positive cases in the country, and brings our cumulative samples tested to 249,998. From the 397 cases that we are reporting today, 389 are Kenyans and 8 are foreigners. Males comprise 236 and females 161. Again, the youngest is a 1-year-old infant. The oldest is 90 years. The new cases are distributed in the following counties in order of the numbers. Nairobi, 239 cases. Kiambu, 33. Machakos, 27. Nyeri, 17. Busia, 16. Nakuru, 12. Mombasa, 12. Kajiado, 10. Migori, 8. Uasin Gishu, 8. Kericho, 5. Narok, 3. Laikipia, 3. Kisii, Kisumu, Lamu, and Nyandarua, 1 each. If we look at the sub-counties for the 3 counties with the largest numbers, Nairobi with its 239 cases, these cases are within the following sub-counties: Westlands 22, Langata 21, Makadara 21, Embakasi 19, Dagoretti North 18, Embakasi West 18, Kasarani 15, Embakasi South 14, Roysambu 13, Kibra 12, Starehe 12, Dagoretti South 10, Embakasi Central 10, Kamkunji 10, Embakasi North 9, Ruaraka 9, and Mathare 7. Kiambu's 33 cases are from Kiambu Town 8, Kiamba 7, Kabete 4, Kikuyu 4, Ruiru 4, Juja 2, Limuru 2, Gatundu South, and Lari 1 case each. Machakos, which is third with 27 cases, which come from Athi River 24, Machakos, Kathiani, and Mwala 1 case each. The rest of the county breakdown is given within the document which you shall receive. Today, I'm also happy to inform you that 642 patients have recovered, of which 587 are from the home-based care program, and 55 have been discharged from various hospitals. This brings the total number of recoveries so far to 6,258. And I want to take this opportunity once more to thank our healthcare workers for the good job that they're doing out there in the front line. However, at the same time, I'm sad to inform you that today we have lost a record of 12 patients to the disease. And this brings our fatality rate to 250 at this point. I want to pass our condolences to the family and friends of all those who have lost their loved ones. Thank you very much.
Good afternoon. My name is Purity Museo from KBC. two concerns. One, how many counties have achieved the 300 isolation bed capacity as required so far? And number two, we've seen some media personalities coming out and sharing their status that they are positive. But now, my question is, we've not been able to see any target testing to those places. When do you intend to conduct the target testing to those areas and other areas where positive cases have been recorded but still no target testing that has been embarked on? Thank you.
Hi, my name is Graham Kajilo from The Standard. My question is with regards to, yesterday you've spoken about stigma a lot. And my question is how these cases are being handled, especially in private hospitals. We've seen a directive from Mandera County, for example, that COVID-19 patients should not be handled in private facilities. We've seen the way Shalom Hospital was handled due to COVID-19 infections as well as Pumwani. I would like to ask, do you think the way the government is handling these issues is contributing to stigma? And isn't there a way, another better way that these issues could be handled instead of, because most patients actually, they'll get themselves in private facilities before they get to government facilities. Is there a better way that this issue could be handled? If actually we have all the preventive equipment, how other way can we handle that issue?
My name is Anita from NTV. I just have several questions. The first one being that it seems that men continue to be the highest number of cases that we keep seeing from the statistics. And my question is, what is it about men that is making them susceptible to the virus? The second one is that there's a document that seems to be circulating, titled, and it's written that it's coming from the public, from the Ministry of Health, stating that it has certain conditions about alcohol consumption in the country. For example, it states that people can't consume alcohol in public places such as parks. My question is it true? Is it coming from the Ministry of Health? And third and lastly is that Oxford University stated that, or say that they have come up with a vaccine. They've had a breakthrough. My question is, are you in talks with them that possibly could come here and we could also get to experience those trials, as well as in Kenya itself, KEMRI and all those other organizations? How far are we when it comes to vaccines? Is there a trial that's coming up? Are there any participants that have been selected? I'd just like to know how far we are with all of that.
Okay, thank you. The counties, as you know very well, that His Excellency the President has called for a meeting with the governors. I think it is happening on Friday. And the purpose of that meeting is again to be updated, for all of us to be updated and be informed about the level of preparedness within the counties in terms of meeting the target that was set by His Excellency the President of attaining 300 beds in every county. And as a ministry, we have been working very closely with the counties. We are continuing to work with them. And we are also monitoring and assessing and supporting their efforts to attain this target and to, in general, improve their level of preparedness. We will for certain know by Friday, after the Friday meeting, what the levels of preparedness of the counties are. But from where we are, we know that every effort is being put in meeting that target, and we suspect that a very large number of counties will meet that target come that date they have with the President. So let's wait for the outcome of that meeting to be informed where we stand on that. Media personalities, as I've read also in the paper, and I would want to say that I think it's a positive thing when people in high office or who are celebrities or in media come out and pronounce their status. That is one way to destigmatize the disease. If you remember, with HIV, it was the same thing. But of course, when we talk about COVID, it is not anywhere near HIV in terms of the reasons why it was stigmatized. So we need to encourage that when people do come out and state their case. It helps us to be able to destigmatize the disease, to recognize that this is a disease that can affect anyone, and it is a disease that if we handle it well and get it at the right time, that most of the people will recover from this disease. Targeted testing. I think when we say we are doing 3,000, today we said we did over 3,000. Let me see exactly how many we tested today. 36, 37. That is a large number of tests. And I believe and I'm certain that quite a number of these tests is still targeted testing, going to certain places to look at a particular spots. So we have not, in a sense, stopped any of this targeted testing. I think we're doing it. We may not be doing it at a scale that we had done it in some points in the past. But targeted testing is still going on, as well as testing of contacts and contact tracing. That's happening. And so I would not entirely say that we are not doing targeted testing, unless by targeted testing you mean something else in terms of what your expectations would be.
Just a clarification,
Yeah.
Because some of them came out even last week to announce their status that they are positive, but we haven't seen any target testing in any of the media houses, despite reporting cases weeks ago. When do you plan to do target testing in media houses that have reported cases?
Oh, you mean in media houses?
Yes, sir.
Okay, I didn't get that. You mean the media houses have made a request for the ministry to come and test people in those media houses? That's what you're saying, correct?
My concern is it supposed to be a request once a place like a media house reports one or two cases? Is it supposed to be a request, or it's automatic that the ministry is supposed to do target testing in that particular area?
That's not called targeted testing.
Okay.
That is called contact tracing.
All right.
And that happens. That is part of the protocol, that once somebody is found to be positive within a particular work environment or any other environment, then that person contacts must be traced. So contact tracing is part of the protocol. It happens. But beyond that, what might happen is that, for example, in an institution, if such a situation arises, the institution may then wish to do a broader test of people within that institution on that building. And I think that is what I was driving at, whether that request was made. And that usually can happen. And the ministry responds to such a request and will send a team to do much broader testing. But the contact tracing is part of the protocol and procedure, and it happens because it's important to do that in order to be able to contain that virus within that environment at that particular time when a positive case is discovered. Graham, stigma, I think I spoke about stigma, but the practice and what we are seeing out there, whether it is contributing to stigmatizing the disease, from where we stand as a ministry and the advice and direction we provide, this is any other disease. We would not want this disease to be stigmatized, and we would want to fight any moves that will lead to stigmatization of this disease. However, we are aware, and perhaps as a natural reaction of not being very familiar with the disease, some institutions may fear even taking in patients who are COVID. When that happens, then of course that leads to some level of stigmatization. And we want to say here that institutions first must be prepared for the reality that we have community transmission of COVID-19, which means that we will get people who will present with symptoms of COVID-19 in our facilities. And we should treat them just like we would treat any other person who comes in with symptoms for another disease. But preparedness means that the institution must have set itself up so that it can deal with handling of COVID-19 because of its infectious nature. So we should not have institutions exclusively turn away people who show signs of that are consistent with COVID-19. I think that is not proper, and that is stigmatizing the disease, which is something that we do not want to happen. It only ends up hampering the efforts of the COVID response. Men versus women. Why more men, less women? I mean, there can be very many theories to try to explain that. And there are also scientific studies that are being undertaken to try to understand that. At this point in time, I think we have no clear answer why more men are affected than women. The course of the disease is generally the same in both sexes. So I think that is an open question that will be answered in time once some of this research sheds light on the factors. There have been theories about, for example, the number of receptors in certain organs in men, that they have a higher density of the ACE receptor, which is what the virus uses to invade cells, that there are higher densities of these receptors in certain cell types in men and so on. But that remains to be proven to be, to associate that directly with the increased infection in men. So let's wait and see what research will reveal. Dr. Kuria will respond on the document that you talked about, which on alcohol utilization. With respect to vaccines, yes, there's tremendous effort out there. There are more than at least 200 vaccines that are being tested out there. Some of them have progressed to higher levels of testing. In the process of testing or clinical trials, there are several stages. There's what's called phase 1, phase 2, phase 3 of a trial. These phases address different things. The first phase and the most important part of that is really to determine the safety of a product. That's usually the first thing that you want to do, is to test safety. So most phase 1 trials will test safety of the product. What does this product do? Does it cause any other adverse reactions in the subject? There may be some level of dosing. It requires a smaller number of people. You move on to phase 2 now, which still focuses on safety, but might begin to look at what is called efficacy, which is how effective is the product. And then you go to, once you get through that, you go to phase 3, which is a larger number of people, and there you are generally focusing on the efficacy of the product. Does it do what it was intended to do? So we do have, I think, a couple of vaccines, especially in the US and I think in the UK as well, that have gone through some of these phases and are now entering the large-scale phase. That's promising, because if a vaccine has proceeded to that stage, it means it has passed these other tests. I heard that there is a vaccine in the US that's now entering phase 3. We know that there is a vaccine in the UK that is also progressing well. So the entire world is looking to a successful vaccine that comes out in good time and that will be able to protect people from getting COVID-19. The chances are that we may get a number of products that will then have to be applied. I can see that there are many countries that have already placed huge orders for these vaccines. I was watching, Citizen actually was informing me yesterday about what's happening in some of these countries. Now you know that just like we told you about our testing, limitations with testing, the limitations of getting the equipment and getting the reagents because of the global supply chain and the demands. and the preferences. You know, the more developed, richer worlds where these products are produced are the ones to benefit first, and we end up in the end of the queue. That is also something that, of course, is of concern with respect to any vaccine that might come out. And there are discussions at many levels, at regional and intercontinental levels, to make sure that low and middle income countries are not left out in terms of getting this vaccine. And I know there is quite a bit of activity there. We have our regional bodies, our continental bodies that are working to strike deals so that even a low middle income country should still be able to get those vaccines once they become available. I think there is intense diplomatic effort going on to see that there is that certain level of equity in terms of the distribution of these vaccines once they come out. And we hope that low and middle income countries, our country included, that we will be among those who will be able to get some doses of those vaccines when they are ready to be used. I think I have responded to the questions that I was asked. I have asked Dr. Kuria to respond on the specific one regarding the document you mentioned that you saw circulating in social media. Dr. Kuria.
Thank you very much, Kash Rashid. I think the document you referred to is a draft document that is circulating on social media. That is a draft legal notice. It's a notice that has no number. So we will not talk about a legal notice that has no legal notice number. It's a draft. It should be under the office of the AG. And once it gets a number, it becomes a legal notice, and you can talk about its contents. But I know it is circulating and maybe somewhere in the offices for comments from the technical officers who address the contents of the legal notice. But by and large, if it is there, it should be aiming to address the issues of alcohol consumption that were addressed in the Presidential Directive of 6th July that we talked about yesterday. That the sale of bars remain closed and the sale of alcohol is limited to takeaway only. I guess that is what the document is trying to address. Once it becomes a legal document, then we can discuss it further. Thank you.
Thank you very much. Anoxicaulia, can we leave it for tomorrow, please? Huh? I will take only your question.
Thank you so much, sir. Anoxicaulia from Citizen TV. Yes, we talked about the prevalence in men, but there is also the fatality. Say that more men are more susceptible to the disease. But there's some theories that came out. I don't know how true they are. First of all, about the concentration of an enzyme called SCE2, angiotensin converting enzyme 2, that is more concentrated in men. Does it have anything to do with why we are seeing more men succumb to the disease or not? And does it make the men more susceptible? Another question that I just wanted to ask is about, we have seen quite a number, not many, but people who just, for example, they start feeling or having symptoms, then they collapse and die. What is really happening to them? Is there an explanation to it, that someone today shows symptoms and in the morning, or even when they are being rushed to hospital, they just simply collapse and die? Is there something that is probably was happening even before the symptoms manifested themselves?
Enoch, you're becoming a scientist. Enroll for a PhD. I will be very happy to supervise you. But as I was responding to the issue about male versus females, I said that one of the theories is the expression of this particular molecule called ACE, which is a receptor. It is the receptor. It means that the virus docks on it and enters the cell. Yes, there have been theories that perhaps it could be that, but there are many other theories. So we're really not clear. And as I said, as the science around this pandemic develops, we will know in time, including your other question regarding why is it that some people, the disease just progresses so fast to the point of death in a very short time. And that has been reported in many places. Yes, there are people who, once they get it, the symptoms, they show the symptoms, and very, very rapidly progress to a stage where a very critical stage and may even die. These are some of the unknowns about this disease that we hope in time will be unraveled. But again, we also have to understand that maybe there could be certain, because we have to understand these individuals, why did they progress so fast? Could it be that they may have had certain underlying factors? What is the influence and the weight of these underlying factors? Because right now we know about the comorbidities and others. It could be possible that there could be other more underlying factors that have not been understood yet, including the weights of these comorbidities, their combinations that could result in something like this. So I think there's a lot we are going to learn as we move through this pandemic. Thank you.